Good afternoon. Thank you for attending, whether here in person or on the online platform. Thank you, Dr. Ayman, for your introduction and for organizing this conference. So today I'm going to be talking about the journey of rare disease diagnosis in the Arab population. And what I'll be talking about exactly is the genetic diagnosis. So the genetic diagnosis, for those of you who don't know, is done via several techniques like whole exome sequencing, targeted mutation screening. Sorry. Which one? No, but this one. Okay. Copy number variation, again, so it's genetic diagnosis done via several techniques. What I'm going to be talking about is an overview of rare diseases seen in our genomics laboratory. Then I'll move to the challenges faced in the genetic diagnosis in this particular population, how we overcome these challenges at the laboratory setting. I will go over a few interesting diagnostic cases and then my take-home messages for you for today. To start with the overview of rare diseases seen in our genomics laboratory, first of all, our genomics laboratory is BioFet Genomics Laboratory. It's been on the market since 2012. It is the first CAP accredited lab in the MENA region for NGS technologies. And it was the first lab to do whole exome sequencing in 2014 in-house. So it is divided into two main sections, reproductive genetics and diagnostics. For reproductive genetics, we offer pre-implantation genetic testing for monogenic disorders and haploidy structural chromosome rearrangements. So the stats or the statistics that I'm going to be showing you today are mainly from a pre-implantation genetic testing for monogenic disorders. And the second section or second department is the diagnostics, where we perform in-house tests to reveal genetic mutations that are associated with genetic disorders. So, again, just like an overview of the diseases seen in or processed for pre-implantation genetic diagnosis from 2019 until present in BioFet. We see that HBV or beta thalassemia and the sickle cell anemia is the most prominent one, accounting for around 30% of the cases. And then cystic fibrosis comes second, spinal muscular atrophy, and so on and so forth. So these are the mostly 10 most relevant disorders that we test for PGD and BioFet. In addition to PGD, these are the most, the 10 first genes that we find mutations or that we reported mutations in, whether disease causing and carrier screening or diagnostics, again from 2019 until present. G6PD is the most prominent one, MEFV, beta thalassemia, adrenal hyperplasia, cystic fibrosis, and so on. So just as a reference point, so this is what I showed you is what we see in the lab, but this is in comparison to what the rest of the world sees. So basically the most common tested disorder for PGD in the range of 10 years of collected data is cystic fibrosis. HBB, which comes first in what we see, comes fourth across the world. So that being said, just after the general overview of what we see in terms of disorders, I'd like to walk you through a bit of the figures that are seen in our lab, basically. Just bear in mind, these are not representative of the general population. These are only patients that are presenting to the lab who probably know that they have a genetic disorder in the family, who are consanguineous, or they've been educated by their genetic counselor or their physician that this is something that they should do because they are originating from a population where consanguinity and endogamy is high. So these statistics are from carrier screening tests performed on Middle Eastern individuals since 2017 at VIAFET. So the rate of consanguinity is 58.41%. 97% of individuals are at least carrier of one disease-causing variant. And on average, 2.4 disease-causing variants are present in every individual, which are, I believe these are a striking number, especially for the consanguinity rate. Again, just to take you in a bit in depth in what we saw. Out of 2,000 or almost 2,000 carrier screening tests performed on Middle Eastern individuals, 458 couples were consanguineous. Out of these 458 couples, 48% of them presented a risk of having an affected offspring, meaning that we found shared genetic disease-causing variant in their carrier screening test. Which is more interesting is the fact that non-consanguineous couples that are at risk of having affected offspring, the percentage was 10%, which is, I believe, is not a little number. Meaning that genetic diagnosis or carrier screening, even more specifically, is presents itself as a crucial test for pre-marital screening. What are the challenges that we face in genetic diagnosis and how we overcome these challenges? I'm going to talk about each challenge and how we're overcoming it straight away. So I'm going to talk about 6 main challenges. The challenge of an understudied population, the challenge of the medical system and the lack of access to medical history, the variant of uncertain significance, which I'm going to be referring to during my talk as VOS, lack of genetic counselors and lack of public genetic education, and the cost of tests. To start with the understudied population, why usually an understudied population poses a challenge for diagnostics? Because when we're doing the analysis or the trying to reach a diagnosis, we don't have a reference database for this specific population. So that poses a challenge for filtering out variants and or shortlisting rare variants. So we end up with more variants than we should, or we end up doing more work than it's necessary. Then the discrepancies in variant classification between clinical databases and our population, because obviously these clinical databases are based, the data is based on populations that are more studied than ours. So this skews the results towards population that is not representative of ours. Lack of founder mutations database. Lots of papers are published concerning founder mutations, but they're scattered. So that means that the information is not present in one place. We don't, as clinical scientists, we don't have access to this information in one go. So this makes our job harder. And the use of panels generated based on information collected from different populations data. And this is, again, another challenge. And I'll show you a few examples of why this is a challenge and how we overcame it. So overcoming the challenge of understudied population, the first thing that we did is to build our own reference database. We built it on around 2,500 individuals' genomic data. The majority are Arabs. And it helps us basically in identifying artifacts, population-specific variants, which are polymorphisms, and to filter based on rare variants. In addition to overcoming the discrepancies between what is reported in the clinical databases and what we see in our population, we do the extra mile of work. We check several databases. We don't base our analysis on one particular database. We widen our search, and we perform other lab tests to confirm the diagnosis, which, for example, segregation analysis. And this is one of the cases where this lady had her whole exome sequencing done because she had a diseased child, male. And she did her whole exome sequencing in an external laboratory where they reported an NDP X-linked variant as pathogenic. So she presented to our lab trying to do PGD on this particular variant. We checked this variant in our population database, and we find it to be at a very high frequency. So we asked for her male siblings. We found that they're all hemizygous for the same particular variant, and they're asymptomatic, meaning that the pathogenicity here is not accurate. It's not a pathogenic variant. Again, to overcome the founder mutation, a lack of founder mutation database, we keep an updated database ourselves where we collect all the data, we keep our statistics up to date, and we include all the findings that we find from what we find ourselves and from the published data as well. How we overcome the panels, the fact that we go for a global approach. We don't go for panels as the first step. Even if it's a hearing loss or like a panel that is straightforward, we first start with the global approach. And then this is an example why. Basically, this is a patient who presented with profound congenital hearing loss. She did her NGS panel for hearing loss in an external laboratory, which is a European laboratory. They used their hearing loss NGS panel. The result came negative. When they presented in our lab, we did the whole exome sequencing, and we found a homozygous slightly pathogenic variant in a gene that causes deafness, but it's outside the European panel. So that, if says something, it says that the population upon which these panels are based, they are not representative of our own population that we study. Again, to even stress more on the fact that this is not a population that is similar to any other populations that are already published. In 2021, 34.41% of our reported variants, whether carrier screening variants or for diagnosis, they were novel. So basically 34% of our reported variants, they're not present in ClinVar or in HGMD. So they're completely novel. This is one case where we found a novel variant in a patient presenting with microcephaly, mild global developmental and speech delays, failure to thrive, and facial dysmorphism, where the clinical diagnosis doesn't pinpoint to any particular disease. We found a homozygous pathogenic variant in a gene that is associated with Cohen syndrome. The patient is homozygous, although his parents are non-consanguineous. And that is pointing out to the fact that the parents are originating from a very endogamous population where the couple marry from the same geographic region or ethnic background. So everything that I've just mentioned plays a huge role in our diagnostic yield. So in comparison to other laboratories' diagnostic yield, our diagnostic yield is higher due to the presence, again, of the reference population and everything that I've just stated. So for positive cases, we have 72% of our cases are positive. Now here, if some of the patients that present for whole exome sequencing or for diagnosis, sometimes they don't have a clear genetic disorder, like for example, autism or infertility, but still, or their physicians, they insist on going through this pathway, or the patients themselves, they want to be reassured that they have a negative whole exome sequencing result. So if we remove these cases where there's no clear genetic disorder, the diagnostic yield increases to 94.12%. The second challenge is the medical system and the access to medical history. I'm going to give you straight away a case where we faced this particular challenge. We had a case of siblings having craniosynostosis and flattened head and a positive family history from the mother's side. when we did the whole exome sequencing based on this particular information, the result was negative. But they consented for incidental findings. And one of the incidental findings in one of the children, which is this one, was a homozygous pathogenic variant in MCCC2. We released the results, and after a year, the new pediatrician of the child contacted us, asking us to change the report and moving the incidental variant to primary variant because his clinical diagnosis and the laboratory tests were pointing towards methylcrotonyl carboxylase deficiency. So basically, had we had the correct medical information from the start, we would have had a primary result and not a negative result with an incidental finding. How we overcome this? We have an in-house genetic counselor who follows up with centers, physicians, and doctors, ensures to collect all the relevant medical information and to communicate the findings to the physicians and patients. In addition, they provide the necessary genetic education and support for the patients when needed. VUSs, I think this is not only a challenge for us, it's a challenge for the physicians. So just a brief history of why variant of uncertain significance are difficult to classify, mainly for three reasons: lack of sufficient population-based statistical evidence. We don't have enough functional evidence to pinpoint the nature of the variant, and different evaluations by clinicians and researchers. So basically, the genetic counselor has to pass on the message to the patients and physicians that nothing's for sure about the diagnosis. How we overcome this? We undergo, like the variants undergo thorough variant evaluation, whether it's clinical evaluation through the patient's phenotype, segregation analysis, literature search, or assessment of the effect on protein structure and function, whether by the information available in the databases or functional studies and in silico predicting tools. So basically, the variants of uncertain significance that we report are mostly tilted towards pathogenic, but the lack of evidence cannot classify them as a definite pathogenic. So one of the cases that was a successful case of VUS, the couple were first-degree cousin. They had a child, male child, who died of with no clear diagnosis or congenital heart malformation. And then we found a variant in the ZIG3 gene, but it was a VUS variant. So by segregation, we found that the mothers, obviously we found this mutation in the mother because the child was already, we didn't have a sample from the child. We found this mutation in the mother as a carrier. And by segregation, we found that her mother as well was a carrier. And by digging more into the information, we found that the mother had two siblings, male siblings, who died from the same phenotype as the child. So we confirmed that this variant is important enough for them to go with it through PGD. And the mother delivered two healthy boys through IVF PGTM after the genetic diagnosis. Lack of genetic counselors. Again, another case where lack of genetic counselors was basically, it made the patients go through the worst of losing even more children without knowing the genetic diagnosis because no one basically was able to point them towards a genetic diagnosis when they were having deceased child one after the other. We found in them basically three variants. Two were pathogenic, and they were explaining, each was explaining one of the children's death, and one VUS variant that was suggestive or probably explaining the rejection of the milk. Lack of public genetic education. This is another case where lack of public genetic education was devastating to the couple. After losing three children when aged 2 to 3 years old, they stumbled across ViaFet just by online search. And because they had a 20 days old girl that they were scared that they would lose as well. So they came to the lab. We found a novel likely pathogenic variant in a gene that causes heart, like basically sudden death. The good news was that the baby girl was not even a carrier. Cost of tests. Usually when we have a case where the couple is not consanguineous and they have a child who is presenting with a genetic disorder, the best way to go is to go for trio analysis, because we expect that the child has a de novo variant, or depending on the disease basically, but in general, this is the suspicion. And again, depending on the disease, several factors plays a role. But for us, because this is not covered by insurance, and the patients, for them to know the answer, they need to pay a lot. So we start by doing only the analysis on the affected child. We don't go for trio from the start. If we find something, or if we find several things, we take them forward by segregation. If segregation confirms a diagnosis, we take it forward. However, if nothing is suggestive of a positive finding, then we go for trio analysis. So this reduces the cost on the patients and allows them at least to have an answer or a diagnosis at the end of the day. So I have two cases. One is with a child with seizures, infantile spasm, and developmental delay. He had an initial clinical diagnosis of West syndrome. We found a de novo, after segregation, of course, we confirmed as de novo, likely pathogenic variant in COCNA1E, which is associated with developmental and epileptic encephalopathy. Another case where, again, the child was presenting with facial dysmorphism, developmental delay, and the genetic diagnosis confirmed Noonan syndrome. And this as well was done only on the child and segregated on the whole family. So I still have a few more minutes. I'll go over a few diagnostic cases where they're interesting because they have a twist in them. The first one is lady got married twice. In the first marriage, she had a fetus abortion where the baby was, she was a female, and she was presenting with left heart hypoplasia, a single umbilical artery, fluid collection in the abdomen, and that was detected around 12 weeks of gestation. In the second marriage, she had the same similar phenotype, but in a male fetus. So during abortion, they collected the sample from the child. We extracted the DNA. We checked, and it was a likely pathogenic variant in the KMT2D gene associated with Kabuki syndrome 1. Why there's a twist in this case? Because both of the children, they presenting with a similar phenotype. No further analysis was done. However, this is suggestive of gonadal mosaicism in the mother. So probably, and PGD or PGTM can be a preventive measure for future pregnancies. Another case of CNV detection, where this child who we did the analysis for was an IVF child, because his sibling, brother, and cousin, they had Hammam syndrome with the IRX5 mutation, where we did the PGD for the child to just like transfer a healthy, non-carrier or non-affected Hammam syndrome child. However, the child presented after birth with dysplasia of the corpus callosum, and he was diagnosed basically with lissencephaly. We detected a 17p deletion of 4 megabase in the 17PR, and this is where we had a confirmed genetic diagnosis of Miller-Dieker lissencephaly syndrome. The twist is that sometimes these things are unpredictable, even if the child is an IVF child, where he's not carrier of any IRX5 mutation, but he presented with another disorder randomly. The case number 3 is for an interesting case, actually. These are sisters to a consanguineous couple. Their whole exome sequencing was done in several labs. the result was coming or inconclusive or negative. It was sent to New York, it was sent to Europe, it was sent to several labs, and still it was negative. We detected a CC2D2A gene associated with Joubert syndrome. And for the physicians of you who know that Joubert syndrome has to present with the very specific molar tooth sign. So after the genetic diagnosis, the clinician ordered the MRI and they found the molar tooth sign. So in this case, the genetic diagnosis was indicative for the clinical diagnosis. This is a case of incidental finding. So this is a child who presented with gallbladder stones. But we found, obviously they consented for incidental findings, and we found an ABCC8 gene mutation, a pathogenic one, associated with hyperinsulinemic hypoglycemia. In this case, after digging more into the family history, we realized that the father had diabetes mellitus type 1, which in the adulthood, this disorder can turn to diabetes. So basically, incidental finding was the one that was the reason why we found this variant. And the last one is just to pinpoint the importance of looking at all the syndromes and all the phenotype that can be associated with a specific symptom. So this is a case of infertility. The woman presented to the clinic to just know why her AMH is low, and she's not responding well to stimulation. And she had an absence of menstruation for 3 months. We found a pathogenic variant in the FOXL2 gene. And the FOXL2 gene causes ptosis as well. So the eyes are not very well. Yeah, it's a very distinctive eye phenotype. So, but the gynecologists were not able to pick that up. Had they been able to pick that up, they would have at least known from the start and saved the patient several failed IVF trials. So just my take-home messages for you for today. The collaboration should be more prominent between the region's laboratories and research institutions to put together all the data that is being found in this population. Genetic testing should be intuitively considered in the clinical setting, especially in population, and if the patients are originating from population where endogamy and consanguinity is very high, or whether they're consanguineous or they have family history. The importance of global genetic testing approach in the Middle Eastern and Arab populations versus panels. Publication of case reports of like the laboratories and the institutions that they're finding something, please publish it because it will help others as well. Clinicians should not be burdened by VUS because as one of the papers, there are plenty, but I wanted to show you one that is very striking. For inherited retinal dystrophies, they took forward the VUS variants that they were found across the years, and they reclassified them with the new databases and the new information that is present now, and with a bit of functional assays. 70% of these VUS variants were reclassified as pathogenic. So VUS variants can be disease-causing, but we don't know for sure. Laboratories, they should consider including functional assays for VUS variants as routine practice, or develop and fund projects to take forward VUS variants and ascertain their pathogenicity. So my take-home message is that one test can change the life of a whole family and help in the management plan to prevent rare diseases. And genetic diagnosis can be a crucial step towards the fight against rare diseases in the MENA region. This is our team. Thank you very much. And I'll take questions.